everyone, and welcome to Preemie Chats. Preemie Chats is a program that is for healthcare providers and families to talk together about what matters most to you, to explore new ideas, and to learn together. And today is a special edition of Preemie Chats. We're shaking up the format a bit because we are talking about RSV infection, the leading cause of hospitalization in young children. I'm Leah Whitehead. I'm a former journalist, but more importantly, I'm a proud preemie mom. And I'm also the mom of two little ones who had to be hospitalized because of RSV. So this is a topic that is very near and dear to my heart. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, also well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a healthcare professional or a family, then I invite you to go to the CPBF website at canadianpreemies.org. And also, November is a very big month for preemie families everywhere because November 17th is World Prematurity Day. So the theme for this year is small actions, big impact, immediate skin-to-skin care for babies everywhere. And we have a full month of incredible ways to recognize World Prematurity Day. I've added a different URL there at the bottom of the screen. Again, invite you to go and check that out because you will see all the incredible ways that we're recognizing World Prematurity Day. The entire month of November, we're going to do our live sessions as usual on Fridays, but we will be focusing on skin to skin in line with this year's theme. We're going to be doing a special edition of Preemie Chats on the 17th, which will include lots of content from both healthcare providers and families. So you won't want to miss that special day. And of course, don't forget to wear your purple. And then on November 22nd, there will be a scientific Preemie Chat where doctors will be debating their different approaches to skin for babies born at less than 26 weeks gestation. So that will be very interesting and invite you to tune in to that as well. There's lots of resources on the Canadian Premature Babies Foundation page, but again, this month especially, go check it out, see how you can be involved and help us create a brighter future for preemie families everywhere. Today's session is live, so we invite you to please bring your voice to this table. Leave comments and questions in the chat, and today we're going to address them after all of our presentations. So if you have questions, leave them in the chat and we will try to get to them today. It is through rich conversations like the one we're about to have where we can advance, practice, and learn together. So please participate and also let us know where you're watching from today. As I mentioned, the format of today's episode will look a little different because we have three guests who will be presenting, and then after that, we will have our Q&A time. We're going to have Dr. Bosco Paes joining us first, and he will discuss the impact of this disease and emerging strategies to prevent it. Then we'll have Fabiana Bacchini, CPBF's executive director, who will explain why the foundation did a survey about parental knowledge and understanding of RSV. The results will then be presented by Dr. Barry Rogers-Gray, a specialist in the area of RSV. And then we'll round out the day by speaking with Fiona Guy, a bedside nurse, who will share her perspective on RSV health teaching at the bedside. So let's get started because we have a lot of ground to cover today as we delve into this topic that is so relevant for NICU families and healthcare providers, especially this time of year. So I'd ask that you join me in welcoming Dr. Bosco Paes. He is Professor Emeritus in the Division of Neonatology, Department of Pediatrics at McMaster Children's Hospital and McMaster University. He's going to be reviewing the global burden of RSV illness and morbidity associated with hospitalization in young children and briefly address the impact of childhood RSV-related hospitalization on families. He'll also discuss emerging strategies to prevent RSV infection. Dr. Paes has received several teaching awards and has been recognized for his academic contributions by the president at McMaster University and the Pediatric Chairs of Canada. As you can imagine, Dr. Paes' current research interests focus predominantly on RSV in children and thrombosis and hemostasis in the neonatal population. Thank you for joining us today, Bosco.
Wonderful. Thanks ever so much for that kind introduction, Leah. And I would also like to thank Fabiana for the invitation to participate in this event on behalf of the Canadian Premature Babies Foundation. So as Leah has mentioned, my topic is on the burden of RSV illness and new management options that currently are coming out. So here are my disclosure. So I've been on the advisory board and a speaker on at least 2 industry firms, which are AstraZeneca and Sanofi, and I've received a research grant from AstraZeneca to conduct some studies on the cost effectiveness of palivizumab. So as Leah's mentioned, here are my 3 objectives for this presentation. Look at the global burden of RSV illness and the morbidity associated with hospitalization in young children. Look at the impact of RSV hospitalization on families, and then quickly discuss some of the emerging strategies to prevent RSV infection. So this is my first slide looking at the overall burden of RSV across the world. And you can see there are quite a few episodes of RSV in terms of hospitalization. And in fact, when you look at them as a whole, 1/10 of the kids are in fact require admission to hospital. Out of those, predominantly the highest incidences in those less than 6 months of age, and most succinctly, in fact, in those less than 2 months of age. It is important to appreciate that of all the kids hospitalized at the moment, majority of them are previously healthy. On the left side of this pictorial, you'll see the mortality, which ranges between 66,000 to just under 200,000 deaths in children aged less than 5 years. And the risk factors that contribute to this mortality, not surprisingly, highest in children with underlying HIV, and then infants who are extremely low birth weight, and those who are immunocompromised. Where do these deaths occur? They occur predominantly in the low-income countries. And as you can see on the far left of the slide, 20 to 50% of the deaths occur in hospital between the ages of 2 to 4 months, and 50 to 80% within the community at the age of approximately 1.5 months. Overall, it is estimated in the US that the costs of managing RSV amount to $3.13 billion in terms of direct medical costs. So this is an interesting study looking at RSV hospitalization rates in preterm infants, and it's a population-based study conducted by Caroline Hall in Cincinnati, Ohio, Rochester, New York, and Nashville in Tennessee. In the first column, you'll see the gestational age of the infants, and in the third column, the RSV hospitalization rates. Notice that between 29 and 34 weeks gestation, there's very little difference in terms of the RSV hospitalization rates. But overall, the hospitalization rates are highest in the youngest gestational age categories, especially in those less than 29 weeks gestation. Overall, in this study, it was shown that preterm infants have a 3.5-fold higher RSV hospitalization rate than term infants. This is a study conducted by a consortium group in Europe, looking at RSV burden in healthy term infants without any underlying conditions in those aged less than a year. And as you can see, the study was conducted between 2017 and 2020, and they had just over 9,000 infants enrolled in Finland, the UK, Scotland, Spain, and Netherlands. On the x-axis, you will see the distribution of RSV positivity and RSV negativity across those various years. Notice that in June 2020, and certainly during the pandemic year, RSV rates dropped to an all-time low. Overall, in the study, it was found that 26.2% of children who were healthy term infants developed RSV, acute respiratory infection. And out of those who were seen in the outpatients and not admitted to hospital, this constituted just 14%. The overall hospitalization rate amongst these infants was 1.8%, of which 5.5% were admitted to intensive care. This is a study conducted by Ting Shi from the University of Edinburgh and the Centre of Global Health, looking at the risk factors for RSV hospitalization in children aged less than 5 years. And as you can see across 20 studies, on the x-axis, you will see the risk factors. The highest odds ratio of being hospitalized with RSV was in children who were not breastfed. And as you can see, the odds ratios decline slowly, and the lowest odd ratio, but still of equal significance, was in the male sex with an odds ratio of 1.23. This is very recent data from the Impact Group in Canada. In the top panel, you will see the RSV hospitalization rates in 13 tertiary care hospitals across Canada, looking at the pediatric age group. And in this study, RSV accounted for over 2,500 admissions annually, of which 23% were admitted to intensive care. And yet again, you can see that the highest incidence, 49.8%, were in those less than 6 months of age. ICU admissions accounted for just over 28%. The mean length of hospital stay once you got admitted to hospital was 5.9 days. The ICU length of stay was 9.7 days versus those who were not admitted to the ICU at being 4.7 days. In the lower panel, you can see the distribution of admissions across the various provinces. And note very prominently, the highest rates and earliest during the season are in Quebec, as shown in brown, followed by Ontario and Manitoba. The black arrow shows you that during the pandemic, these rates dropped to almost zero. This is a recent study also conducted by Rachel Reeves from the University of Edinburgh, looking at the burden of RSV hospitalizations in 7 European countries. In the top panel, you can see the RSV hospitalizations in children less than a year, and in the lower panel, the hospitalization rates between 1 to 4 years. And what you can see at a quick glance is that in Scotland, Finland, Norway, and Denmark, in children less than 1 year, the rates were 16-fold higher than those between 1 to 4 years. While in the UK, Netherlands, and Italy, the hospitalization rates in those less than a year were 40-fold higher than those between 1 to 4 years of age. This is the same study looking at the length of stay in hospital, and across these 7 European countries, the number of bed days ranged between 10 to 20 bed days per 1,000 children. The median length of stay once you got admitted to hospital ranged between 2 to 4 days, and majority of the bed days were accounted for infants less than 1 year. Of note, the The highest bed days were for children with RSV as compared to all the other viral illnesses, and especially in those less than 6 months of age. Again, this is a recent study from Canada comparing COVID-19 to RSV and influenza. And if you look across this chart, you can see that the hospitalization rates for RSV are the highest as compared to COVID and influenza, as is the incidence of admission to intensive care, 22% being the highest with the RSV cohort. This study was conducted by Chelsea Hansen from Bethesda, and what they looked at was the annual age-specific influenza and RSV deaths between 1999 and 2018. They looked at just over 50 million death certificates, and 1% of those death certificates were for children younger than 1 year of age. On the graph, you can see that the RSV death rate in children less than a year was fourfold higher than for influenza. And you can see as the years progressed, in fact, the rates tend to level off between 1 to 4 years. But notice that, in fact, I'm going to even emphasize further that once you get past 65 years of age, the morbidity and the mortality from RSV closely matches that of children less than 1 year. And we are beginning to appreciate that the elderly are also at significant risk for RSV. So what about the impact on parents? This is a study conducted by Ian Mitchell from Calgary. And in the top panel, you can see the impact on the families in general between 2010 and 2012. And the infants that they looked at were the late preterm infants. You can see on average, both parents spent approximately 7 days while the child was in hospital, and the mean out-of-pocket expenses was just over $700. In the top panel, you can see absenteeism from work, presenteeism when they actually went to work but were functioning suboptimally, the overall work impairment, which is a combination of absenteeism and presenteeism, and activity impairment in terms of everyday activities. For absenteeism and presenteeism, fathers were affected more than mothers. But for overall activity impairment, mothers were affected more than fathers when the child was hospitalized. In the lower panels, you can see the stress experienced. And you can see clearly that mothers are affected more than fathers, not surprisingly. And when you look at both state anxiety, which assesses worry, apprehension, nervousness, and tension, you can see that mothers are affected more than fathers. And again, when you look at trait anxiety, which is a reflection of long-term personality traits, mothers again are affected more than fathers. This was a study conducted by Javier Carbonell-Strani in Spain, together with Paolo Manzoni from Italy. And there are some highlight features once preterm infants are admitted to hospital with RSV. You can see that caregivers experience greater stress and anxiety, poorer health, family health and functioning compared to the control group. The health and functional status of the hospitalized RSV children was also poorer than the controls. And more importantly, after the children were discharged home, the significant family distress extended well beyond the hospitalization period. For us as healthcare professionals, an important message came through that the anxiety that these parents experience may be alleviated by improving parental interactions and relationships with healthcare professionals and enhancing parental confidence about the ability of physicians to manage their child's illness. So some of us can actually take home this message and see that we are a little more diligent about these children when they arrive in hospital. So what's just around the bend for RSV prevention? Not surprisingly, the first target is to immunize the mothers with an RSV vaccine so that the antibodies can be transferred to the child and will be protective for approximately 6 months after the delivery. Then we have the monoclonal antibodies like palivizumab and newer monoclonal antibodies such as nirsevimab that can be given to the child after birth for protection. And then in the pipeline is a live attenuated RSV vaccine, which is still being experimented on and hopefully will bear fruition in the near future. So when we look at the utilization of palivizumab in Canada in the Canadian Registry for Synergists, we see that between 2005 and 2017, we amassed just over 25,000 children who had received palivizumab. And you can see in dark blue that the highest percentage receiving palivizumab are the preterms. This was followed by the group shown in yellow, which is children with complex underlying medical conditions, then those with congenital heart disease, as shown in green, and in purple, those with chronic lung disease or bronchopulmonary dysplasia. It's important to note that even with palivizumab, there does tend to be a breakthrough, and so you can still be hospitalized, but hopefully you will not have as serious an illness if you've received palivizumab. So what's in the pipeline? Well, the FDA has approved an RSV vaccine for children over the ages of 60. Children, adults over the age of 60. And now there are two vaccines, the GSK and the Pfizer vaccine, which have made their way into Canada. The FDA has also approved nirsevimab, this new monoclonal antibody, for children less than 2 years. And more recently, they've approved the Pfizer vaccine, which can be administered in pregnancy to protect against RSV up to 6 months of age. And if you look at the lower part of this chart, you can see the indications for nirsevimab as determined by the American Academy of Pediatrics. So children certainly less than 8 months up to 19 months of age, and the shot will be given just prior to hospital discharge. CLD, BPD, immunocompromise, and severe cystic fibrosis in the second season. And of note, it can be given with the other vaccines. So my take-home messages are, I hope I've shown you the burden of RSV illness, the associated hospitalization, morbidity, and mortality is highest in young children compared to any of the other viral infections. There is significant stress experienced by the families when a kid gets admitted with RSV, which is often overlooked by the healthcare providers. And there are new monoclonal antibodies, maternal and child RSV vaccines, hopefully that will be able to treat all infants and reduce the overall burden of RSV illness. Okay, that's the end of my presentation. Over to you, Fabiana. Oh, Leah.
Thank you so much, Bosco. And like we said at the end, we are going to bring you back and we will have some questions and discussion about your presentation. But thank you so much for sharing that with us today. Our next guest is a familiar face to this audience because she often hosts Preemie Chats, and she is the executive director of CPBF. From her personal journey with prematurity, Fabiana is a tremendous advocate for NICU families everywhere and advises numerous national and international committees and projects, including FICARE, the CIHR Advisory Board of the Institute of Human Development, Child and Youth Health, and is a member of the founding community of Global Alliance for Newborn Care Grants. And that's just to name a few. There's much more I could say about all that she does for NICU families, but I know she'll want to get started in sharing why the Canadian Premature Babies Foundation conducted a survey on RSV. So Fabiana, thank you so much for joining us today and for sharing this information.
Oh, thank you, Leah. Thank you for your kind introduction. But I'm also a preemie parent with a baby who has being readmitted to hospital several times with different respiratory illnesses. So this topic is also very important for me, as it is for you, Leah, and for many parents watching us here today. And we know that parents of premature babies have always shared with CPBF their fear of having their babies getting sick and needed to be readmitted into hospital. And Dr. Bosco Paes just showed through research the impact of RSV and RSV babies readmitted in hospital RSV has on parents from the financial perspective and also their mental health perspective. And last winter, we all saw on the news the increase of the hospitalization from RSV infections in babies and children. Actually, it was the first time that we saw RSV highlighted in the news after many years that we've been talking about this among our community of preemie parents. But parents also continue to question among our network why some babies get protected with RSV prophylaxis while others don't. So CPBF launched a position paper in November 2022 calling for equal access to all preterm babies in Canada to receive RSV prophylaxis, and we've been advocating for it ever since. So I will share the link a little bit later on the comments of the position paper. And in this summer, we decided to create another survey for parents to understand if their knowledge of RSV had changed over the last few years and where the gaps and their confidence in having their babies prophylaxed as new options for protection is becoming available, as Dr. Paes highlighted. So this is very important to us as a parent organization to ensure that all families receive necessary education to make informed decisions for their babies. And I am very happy to introduce you to Dr. Barry Rogers-Gray. He's joining us live from England. Leah, can you bring him on the screen? And he will present the results of our survey. We worked together on the survey for many months during the summer, and we really brought all the families from our community to answer that survey to really understand their perspective from many different communities from across Canada. So Dr. Barry Rogers-Gray holds a PhD and has worked in medical education and communications for 20 years. He first worked on RSV in 2003 and has since been involved in over 30 publications. Notable work includes being part of an international expert group that developed and validated the international risk scoring tool for identifying infants born 32 to 35 weeks gestational age at greatest risk of RSV hospitalization. Barry was also one of the investigators on the EROS study that assessed the burden to parents of having a child hospitalized with RSV. Barry is a member of the proud task force of 24 RSV global experts assembled to help identify solutions to the burden of RSV in low and middle income countries. Dr. Rogers-Gray, thank you so much for joining us here today. I'm actually very excited to share the results of our survey because we have only shared among a very small group of people, and today we are going to make this available broadly. So the floor is yours.
Thank you very much, Fabiana, and thank you very much for inviting me to present the results of the survey. So just to mention, so as Fabiana mentioned, the survey was open between July and August this summer, and there was up to 58 questions within the survey that could be completed depending on the respondents' answers. Here are the demographics of the respondents. So we had 331 questionnaires completed. As you can see, 95% were completed by those who identified as female. And the majority of those had their children, about 2/3 of them between the ages of 26 and 35. And about half had other children. In terms of the location and where they live, the majority, about half, were from Ontario, but there was a good mix across the various provinces. And the majority, about 3/4, were from large cities. I think we need to recognise that the respondents were well educated. 77% had a university education, so that's something to bear in mind. And about 85% had experience in a level 3 NICU. And the respondents, 97% of them had their children were no longer in hospital. So again, just bear that in mind. So in terms of RSV knowledge, about 96% knew what RSV was, and 99% were actually saying they understood how serious RSV was, and 91% believed it to be the leading cause of RSV hospitalization in children under 1 year in Canada. And that ties in very nicely to Bosco's presentation. So it's a recognition there of the seriousness of RSV. In terms of their knowledge about RSV, again, it was a good level of knowledge. Over 80% were classed themselves having a good or very good level of knowledge. But I suppose the reverse of that, around 1 in 5 didn't feel they had a great knowledge of RSV. And before their experience in the NICU, about a third of patients, parents rather, had heard of RSV, a bit more than a third. That was quite interesting to know. And where they'd heard about RSV, the majority, as you can see in that bottom left-hand corner, over 60% was from healthcare professionals. But it was also the experience of friends and family, and even actually direct experience themselves of RSV. Once they're in the actual NICU, about 76% of parents, about 3/4, were given information on RSV. And this was primarily by the baby's nurse, 78%, doctor about 50%, but also printed materials and printed pamphlets were shown to be useful, 72%. And whilst of this, in terms of the information of RSV, 76%, again, about 3/4 of those who were provided information were given information on how to reduce the risk of readmission. But actually, following discharge, only about just over half, about 50%, 57% of parents were actually then given information following discharge. So it seems that the majority of the information was given whilst in the NICU, but actually post-discharge, there was less information given. Perhaps unsurprisingly, of those who weren't given any information about RSV whilst they were in hospital, 99% of them, or pretty much all, would wanted to have some information given to them. And only about a quarter of them, 24%, received information post-discharge. So these are those who had not received any information in hospital. So a clear need for those who didn't get any information to want information. And also for those who do feel they've been given information and actually have a pretty good knowledge of RSV, still about 20% of parents still felt they weren't confident in that knowledge. In terms of current education, and bearing in mind that, as we saw with the demographics, most parents, 97%, children were out of hospital now. So as you can see, if you look at that left-hand figure though, of those that were had children still in hospital, again, the majority were pretty confident that they understood, they are confident of protecting their child from RSV. Following discharge, again, there was a relatively high degree of confidence here. Again, just over 80% were very confident or somewhat confident of protecting their child after discharge. But again, we flipped that around, 1 in 5 or about 20% did not feel confident. So following discharge, about 71% searched for more information on RSV. And as perhaps to be expected, the most obvious route for finding that information was an internet search. That was put down by 84% of respondents. But also the family doctor and the paediatrician, about half, asked for information from them, and a quarter went to the Canadian Premature Babies Foundation. So this, I think, is quite an interesting one here. So for those who felt they received enough information and education about RSV, firstly, were they able to feel they were able to advocate for their baby or child? And about 50% said they were. And in terms of understanding all the risks, 50% approximately felt they understood that. So that's quite interesting. So these are parents who felt they were given, a good level of information. Still, only about half of them felt particularly confident in being able to advocate or understanding all the risks, even with that information. Once we're given that information, though, you can see a high level, around about 3/4, took all those precautions on board. So in terms of prevention, and this is looking at sort of prevention in general. So this is all childhood vaccinations and immunisations. So 99% of respondents understood the importance of vaccinations and immunisations in general, not specifically to RSV. And there was a high level of confidence, again, in these vaccinations and immunisations. Again, 93% were confident or very confident in them. However, when we're talking specifically about premature infants, about a quarter, 24%, were still anxious about immunising and vaccinating their premature child. So despite that confidence in general, they were still feeling a bit anxious for their specific premature baby. Bosco has already mentioned palivizumab. And about a quarter of parents, 24%, didn't realise that actually for certain high-risk groups, palivizumab is available freely for babies in their first winter. And about 2/3, 65%, only received information about palivizumab whilst in the NICU. So there's a clear sort of need there to increase awareness. 75% of babies, though, did qualify for prophylaxis. And it's interesting, 75% qualified, but only 65% were given information about it. And in terms of those who were actually qualified for palivizumab, 97%, so a very high level in confidence, particularly in palivizumab. And that contrasts interestingly with sort of that 24% who are feeling anxious about immunising their baby. Actually, when you talk about the RSV prophylaxis, actually there was a high level of confidence there. Bosco mentioned nirsevimab, the long-acting monoclonal. And actually, 4 out of 5 parents, 79%, had not heard of nirsevimab at all. And interestingly for me, for somebody from the UK, well, we're not allowed to really sort of mention any drugs or medicines on the TV or radio. It was through the TV and the radio that actually the majority had heard about, nearly sort of approaching 60% had heard of nirsevimab. But despite, you'd say, 4 out of 5 hadn't heard of nirsevimab, there was, again, a high degree of confidence. Again, 93% had some degree of confidence, and of those 37% were very confident in their baby receiving nirsevimab. And actually, if they would acceptability of nirsevimab, 3/4 of parents, 75%, said they would accept nirsevimab, despite the majority not knowing it. In terms of when and where they'd like their baby to receive nirsevimab, there was a clear preference, as you can see in the green bar there, for the baby to receive nirsevimab just on discharge. And after that, it will be within the family doctor or the paediatrician's office. Interesting question. We sort of said in terms of the availability now of nirsevimab as well as palivizumab, is there a preference for parents between the two monoclonals? And actually it was a pretty even split, with 54% preferring palivizumab and 46% nirsevimab. And it's important to remember as well that nirsevimab, say 80% of parents almost had never heard of it. And of those, there was only 59 parents in total who said they'd heard of it, but actually 129 would actually prefer it. So again, I think there's a high degree of confidence in both of these monoclonal antibodies. When we look at the reasons for that choice between the two, and it's perhaps to be as expected, it's the single biggest factor when considering it was safety. And that's really due to the fact that palivizumab has been around in Canada, available for 20 years, and around the world for sort of 25 years, versus nirsevimab, which is only very recently, only got approved by the FDA in the USA towards the end of last year. And this is its first season coming up of its use. As Bosco mentioned, there's also a maternal vaccine that's recently been approved. And again, a high level of confidence in this, 73%, nearly 3/4 of the respondents, the parents, will be willing to accept this maternal vaccination to protect their young baby. Now looking at optimisation of education and what in particular the Canadian Premature Babies Foundation can do, and to really increase those knowledge gaps, because even with, as we can see, quite a highly educated, highly experienced in terms of RSV respondents to this survey, there was still quite a lot of need for education. 24% still feeling anxious about vaccinations, 20% still not feeling confident, even when they feel they've had a good level of information. 50% still feeling they didn't feel they could fully advocate for their babies. So in terms of the roots of education, where that can be delivered, as you can see, healthcare professionals, the nurses and doctors are crucial to that. 80% saying they'd like to see that information, but also printed materials as well. And nearly 60% actually selected, you can see in the grey bar at the bottom there, the Canadian Premature Babies Foundation for providing information. And I think another point I'd like take from this as well is that there's no one size, there's no one channel or route for providing this education. There's a huge number of ones where different parents would like to seek that information. But it seems to me as well, by looking at this information, parents don't just want facts, they want to actually be able to give given advice. And that's where you can see with the Canadian Premature Babies Foundation, the nurse, the doctor, there's a lot of educational sessions. They want to actually be taught, not just provided information. And more specifically, how can the Canadian Premature Babies Foundation deliver that education and information? And again, there's a huge variety of different things which were considered in various channels for delivering that education. Clearly, the Canadian Premature Babies Foundation website is a clear resource, but also there's Instagram, there's printed materials as well, Facebook, support groups. There's a whole variety of different channels that could be utilised for delivering that education. And I'll leave it there. Thank you very much.
Thank you so much for sharing those survey results. And I put it in the comments as well, a link to the survey results. So if anyone wants to take a closer look at that, then they can do so. And as I mentioned earlier, we are going to have a Q&A at the end. So I'll say goodbye to you for now, Barry, but thank you for joining us and sharing those results. Our next guest, sorry, I'm playing with papers here, is a bedside nurse, or was a bedside nurse. And oftentimes, as we heard, the teaching on things like RSV come from the bedside. And so we're going to finish up the presentation part of today with RN Fiona Guy, who will be focusing on RSV health teaching from a bedside nurse perspective. So Fiona Guy is the RSV clinic coordinator at McMaster Children's Hospital in Hamilton, Ontario, and senior administrator for the RSV data management system at Mount Sinai Hospital in Toronto. Fiona's expertise is in neonatal nursing, as she worked, as I mentioned, in the NICU at both North York General Hospital and McMaster Children's Hospital for the first 11 years of her career. Fiona has been running the RSV clinic since 2018 and has contributed to scholarly papers, 2 roundtables for the Canadian Premature Babies Foundation, and sits on the RSV advisory board for the Ministry of Health and Long-Term Care. And she joins us now to share her wisdom. So thank you so much for joining us here today.
Thank you for having me. Okay. So as we can see, based on the survey, a lot of parents need some extra health teaching prior to going home so that they understand RSV and RSV prophylaxis if they are eligible to receive it. Okay, so we're going to discuss parent education and some prevention measures, and then resources, which is very important to be able to send parents home with. So teaching at the bedside is very important, and teaching at the bedside is important whether an infant qualifies to receive RSV prophylaxis or not. RSV is one of the most common childhood viruses. Almost every infant will get it by the time they reach the age of 2, And so it's really important to discuss this with families so that they're aware of signs and symptoms of RSV and severe illness. So we want to explain to them that it is a common respiratory virus that is easily spread. And like I mentioned, all children will be affected by this at least one time by the time they reach the age of 2. It usually causes mild to moderate flu-like symptoms, but there are some babies that are at increased risk for developing severe RSV disease. It's also important to explain the consequences of the severe RSV disease due to babies that are at risk having reduced ability to fight off lung infections and therefore developing bronchiolitis or pneumonia as a result. When and if discussing palivizumab, or as sometimes we call it Synagis, if the infant is eligible, we need to stress that Synagis is not a vaccine, but is a passive immunization that provides RSV fighting antibodies with each dose and may significantly reduce symptoms and hospitalization, but we need to make them aware that it is not preventative. Here's a nice little acronym to remember this, that RSV is a really serious virus. Makes it hard to breathe. This is something that's very simple to give to parents and to educate them. Some signs and symptoms of RSV. So in most children, RSV usually causes mild cold-like symptoms like stuffy or runny nose, ear infections sometimes, cough, low-grade fever, sore throat. But warning signs of a serious RSV infection would be that they're having trouble breathing, they're indrawing, they're having nasal flaring with their nostrils, they're breathing very fast, they start to wheeze, they have deeper and more frequent coughing, they have cyanosis or blue lips or fingernails, they have decreased wet diapers, so they're not drinking as much fluids, and they may have difficulty breastfeeding or bottling. So one of the things that I like to talk to families about is prevention measures, because again, not every infant qualifies to receive RSV prophylaxis, but it's very important to be able to give parents some education on how to potentially prevent their child from contracting RSV. So it's very important to let parents know that RSV can stay on hard surfaces for 6 to 7 hours, porous surfaces such as clothing for 2, and skin for about 20 to 30 minutes. One of the things that a lot of people don't think about is how long these viruses can stay on surfaces and how easily they are transferred. These are some other prevention measures. So a lot of these are common knowledge, but it's really good to reiterate these. So washing hands frequently. Avoiding exposure to infection. So if someone has a cold or a fever, to avoid being close to the baby, kissing the baby, and limiting the infant's exposure to people that are considered contagious or have an illness. Keeping surfaces clean. So again, this plays to the role of the virus staying on surfaces for 6 to 7 hours. So you want to make sure that your countertops and bathroom surfaces are cleaned regularly with a cleanser. I even suggest, especially our phones, wiping down our phones, even your car door handles, the door to your house, the door to your bathroom, things that you're touching very frequently. Avoiding secondhand smoke is also very important because it actually increases your baby's risk of contracting RSV and developing more severe symptoms as a result. And the last one would be avoiding large crowds in places like shopping centers or daycares or large family gatherings where your baby's going to come in contact with a lot of people, especially when there are small children around, such as daycare age or kindergarten. Another thing that is really important to explain to families or to give to families is resources. So as we noticed in the survey, that a lot of people end up looking on the internet. And I think it's a lot better to be able to provide very reliable sources. So one of the sources would be the Canadian Premature Babies Foundation. They have a wonderful information page on RSV and the common respiratory illnesses. And they also have an RSV fact sheet that is in 17 languages. And that is my presentation.
Thank you so much for sharing. You were reading my mind. We were just about to pop up the link for the CPBF resources, and there they were. So that was awesome. Thank you.
Thank you.
And there was a ton of great information that was shared here today. So I'm going to bring everyone back onto the stage, and we're just going to talk about this topic, RSV, and Bosco, I'm not sure. Yeah, we still have you. Great. And answer any questions. So if you have any questions after watching these presentations, just pop them in the comments there. We do have one that came up while one of you was presenting that was just clarifying, is croup part of the RSV infection? I don't know who would like to take the lead on that one.
I can. No, croup is not traditionally part of RSV infection. And as Fiona has pointed out, majority of these kids usually tend to develop an upper respiratory tract illness, which is very much like a cold. And when they get worse, that infection from the upper respiratory tract, which is the nasal passages, in fact, tends to spread to the lower lungs. And then you tend to get a pneumonia associated with that. And with the pneumonia, you produce a lot of sticky mucus, which tends to plug up the airways. And that is why the kids find it very, very difficult to breathe. No, croup is not part of the RSV platform, really, in terms of its presentation. Yeah.
I wanted to talk about the survey results, and it was very interesting to me to see, how closely, I guess, people preferred both interventions. I don't think I can say them, but the one with the P and the one with the M, and yet they didn't have knowledge of great knowledge of what the difference is. So why do you think there was a preference? You mentioned safety, but can we tease out a little bit why people would prefer one over the other?
I mean, I can go first. I mean, I think that the advantage of nirsevimab really is in terms of it's one injection, whereas palivizumab is up to 5 injections once per month across the RSV season. In terms of their efficacy and tolerability and their sort of efficacy and safety, they are very similar in both cases. So there's not a lot to choose from. The one thing you'd say that nirsevimab has an advantage on is it's one injection. In terms of palivizumab, what you've got is the history, in the sense it's been around for decades. So you've got a lot of information on it. However, I think, people seeing them as sort of one and the same, and they are, pretty similar in terms of their work. As been mentioned, they are passive immunoprophylaxis. They just provide antibodies. They're not traditional vaccines. So I think it was interesting, to be honest, that even though, sort of 80% hadn't heard of nirsevimab, they were still, a large number, pretty evenly split between which they'd rather prefer for their infant to get.
And do families get a choice if their child's RSV intervention eligible? I know there's a certain criteria, but do they get to choose which one they'd prefer?
So currently, Ontario is only supporting palivizumab at this time, so there is not an option for nirsevimab in Ontario or Canada.
So I can add to that. We are still struggling with availability in Canada. And so because majority of the provinces recognized that if nirsevimab did become available, it wouldn't be until middle to late December, if not even early January. And as you know, our RSV season has already started. Hence the rationale for selecting across most of the provinces to stay with palivizumab for this season. And hopefully by next season, we'll be geared up sufficiently to have received sufficient number of doses of palivizumab that it will be available across all the provinces. So that's part of the rationale.
Fabiana, I saw you unmuted there too. Do you have something to add?
No, I was going to actually add what Bosco said. There is still not available across Canada. So palivizumab is what all the provinces start this season. So families are not really giving a choice, because at the moment, families know if their babies are eligible or not, based on what Fiona said. The nurses come and talk to the families, see if they're eligible, and then they send information to families. But I think our position as a parent organization obviously is a call to action for all babies to have access, no matter where they are in Canada, and to protect all preemie babies, but also to provide information to all families, because the families told us on the first survey in 2020, and this current survey whether their babies qualify or not, at the moment, they all want information on how to decrease the risk of their babies getting sick. Because you and I, as preemie moms, you know, this time of the year, we get very anxious. We're afraid, right? We're afraid of our babies getting sick. It's approaching holiday season. There's so much going on at the same time that makes parents very anxious. So information is very important for families on how to decrease the risk, especially around the holidays, because families said, should I go to my family gathering during the holiday season or Christmas or Hanukkah, whatever they celebrate? And sometimes the families feel like, how am I going to tell my in-laws that I cannot go for Christmas? So we actually have a letter on the website that it comes from CPBF, why their babies are more vulnerable and why perhaps they shouldn't be going to those gatherings or find other alternatives to see the family during this time. And you have to think, as baby grow, they will become stronger, but we have to protect the babies, especially the ones that are recently discharged from hospitals. As Bosco showed in his survey, in his research, 2 years, like it's very crucial period of time for those babies. So can we, while we still take care of our mental health as parents, that we are not isolated and we still socialize, but at the same time protect the babies, to find that kind of balance. So we have a lot of information on the website on that parents can access, or healthcare professionals or nurses can share with families, because it's very important. As we saw, the nurses are the first source of information for parents. So it's nice for them to share with parents what can they do to have this balanced winter ahead of them.
I know that in our NICU, families always appreciate that letter, because it can be that uncomfortable conversation with people who, you know, have never interacted with premature babies, or if there's prematurities not in the family, then people just don't get the vulnerability. And a lot of people feel that uneasiness of, you know, thinking that it's like confrontation. And I thought it was very telling, Barry, when you were giving the results, talking about how families will say they have a good understanding of RSV and yet don't feel like they have the ability to advocate for their children. And why do you think there's a disconnect there?
Yeah, I mean, my view is, I think it's often sort of information and education. I probably look at it like that. I think there's one thing being provided information, but you've been able to actually understand it and act on that information and be able to advocate on it. And I think with, you know, I know Bosco and Fabiana, and we've talked about it a bit in the past as well. I think it's not just a case of providing parents with information. I think it needs to be tailored and actually provided as part of education specific to their child. It's how you deliver that education. And I think that's the key, perhaps, gap. And that's what that sort of percentage of understanding it and actually being able to really advocate.
And I had to just share a little bit of my experience, because my son was discharged on home oxygen in October. He was a 26-weeker. He did qualify for palivizumab for 2 seasons, actually. But the first season, I was really scared because my older son was 3 years old. And as much as I knew from education sessions from the hospital, the risk that Gabriel had by going home in October on oxygen, it wasn't until his first hospitalization that I really understood the risk, when he was at the hospital for sick children, and they want to take him into the ICU. So that for me was like, okay, this is very serious, right? To see your baby at the risk of being intubated again after all that went through in the ICU. So it's very important to share that with the families, that it is a high risk, but also the impact on the families, right? Like, and how long, or perhaps how long the virus lives on the surface, because we don't know those things. And as Barry said, you can sit down and have this more one-on-one conversation. You know, it's very challenging, limited time with the system, with the nurses' resources, but it's very important, because we don't want those families back in the hospital, right? Because the baby can have a long-term impact of having a severe RSV infection.
Right.
And I think one of the things too is, a lot of the time when you're in, say, neonatal, you kind of have that bubble and you're not thinking about what it's like when you go home until you're home. And that's another thing, is sometimes a bedside nurse, like when I worked in Neo, I don't see patients after they leave the NICU. And so we have a different perspective of that. So one of the things that I do like to explain to parents too, even patients that don't qualify that I may receive phone calls for, is the prevention measure. So one of the things, if you have a child or an infant in daycare or kindergarten, when they get through that door, change their clothes more often, because it can live on surfaces or clothing for 2 hours and surfaces for 6 to 7 hours. So just giving them that extra bit of information so they have a little more autonomy and a little bit more control over their environment, I think is really, really helpful information. And I've definitely had families that don't qualify where I provide that. And I can just feel the relief in their voices to know that there is some things that they can do to help prevent it.
Yeah. And Fiona, you're not one of our roundtables when you had parents of late preterm babies sharing their experience of babies getting back into the hospital, ventilated, and they had no idea because they had received no information before going home with those late preterm babies. And I think that's where our position paper came from, because we heard so many of those stories that we said all babies should have the same access to prophylaxis, so they all protected during the season.
Yeah, I think one of the important things to recognize is, as this new monoclonal antibody comes into play, which is nirsevimab, the target will be all children, certainly in the first year of life, especially those who are younger than 8 months for the first season. That's what's come through from the American Academy of Pediatrics. And we're waiting for guidelines, similar guidelines that hopefully will mature through the advisory committee for immunizations here in Canada, and that'll probably come through in February of 2024. But, the guidelines may be very, very similar. So it's important to recognize that every single child, unlike the current status where we target just the high-risk babies because of cost, and we also want to make sure that the right babies are getting it. But with this new product, every single child will be able to get it under the age of 8 months if we follow the same guidelines as the American Academy of Pediatrics. And nirsevimab has become available in the US, but they're also struggling because there aren't sufficient doses. And this is the point. This is why we stayed with palivizumab for this season. And I think that's important that parents appreciate that.
I think it's worth reiterating Fiona's point, actually, because one of the things, actually, some of the data you showed, Bosco, the actual benefits of taking some hygiene and preventative measures, and actually, if you look during the COVID pandemic, as Bosco showed on his figures, because we were all sheltering, because we had hand gel, wearing masks, and there was literally no RSV cases during that period because there was no spread of the actual virus. Not saying we ever want to go back to that level again, but it shows how effective that can be, just taking these simple precautions.
Yeah. And I know everyone has said that our focus is RSV for this presentation, but don't forget, during the pandemic, with all those measures, and it was a natural experiment with all those measures implemented, not only RSV, but influenza, parainfluenza, and a number of the other viruses like metapneumovirus, and even some of the coronaviruses, not COVID-19, but some of the coronaviruses, they were all at a minimum across the board. But as soon as the barrier got lifted, as I showed you in that slide, there was this huge resurgence of RSV. And so also all the other viruses came into play. So at least we know those measures are highly protective. And if everyone adopted them, it's certainly the way to go. Absolutely. And I would echo what both Barry and Fiona said.
But another thing with that is that I did recognize that a lot of families, especially because when COVID hit, it was right at the tail end of the RSV season. So I was still prophylaxing patients in hospital, and people were very hesitant to come in, understandably. But one of the things is a lot of people would say, well, I'm not taking my baby anywhere anyways. And that's why I stress, well, RSV lives on hard surfaces for 6 to 7 hours. So you may not take your baby somewhere, but you go and get gas for your car. You go and get groceries. You're leaving your home, and you could be bringing that back into the house, and not because you're sick, but because you're spreading it, because you've touched a surface that has RSV on it. So that's something that was really important for me to stress to families, because it's not something that you think about.
Yeah, the preventative measures that you're all talking about are resonating with people who are watching, as you could see from the comments I popped up there. And we do have a couple questions from concerned parents about symptoms of their kids. And so Sarah was asking, what are your thoughts regarding saline sprays and suctioning at home when kiddos are congested? And can we mention how over suctioning can affect kiddos? Because I feel that's not often spoken about.
Well, yes, that's very true. And to be honest with you, I'm pretty sure that that's something that I've definitely talked about. I do definitely advocate for, saline drops if there's something stuck in the nose. But I think there is a point where you oversuction and it actually stimulates secretions more and can actually make them more congested.
Carrie had the comment of what a runny nose and mild cough is part of RSV. My 27-weeker baby keeps on getting all these fall diseases. So like we talked about, this is the season when we start seeing those germs popping up. So how can families kind of navigate what actually is RSV and what is a different kind of virus?
Fiona, do you want to take that one?
No, that's a tough one. A lot of these viruses present with very, very similar symptoms. When it becomes a lower respiratory tract infection, that's when you're going to start to see. So that's another thing, actually, and I wish I had mentioned this in my presentation, but when you're in the neonatal intensive care, for example, I think it's very important as a bedside nurse to explain to them what your baby looks like then. So that's explaining indrawing, subcostal, intercostal, substernal indrawing, what that looks like, because often when babies get discharged home, they're no longer indrawing. Indrawing is a sign that the babies are fighting for some oxygen and they're having difficulty breathing. So I've even had patients come to my clinic before and I'll see that they're indrawing and I say, is this normal for them? And often in that case it is. So you need to know what your baby's baseline is. And then if it's getting worse, then you can determine whether they're struggling a little bit more. Cyanosis is clearly a sign that your baby is struggling if they are blue and they're not getting enough oxygen. And that is when you're going to be going to emerge. But another thing would be wheezing and the nasal flaring where your nostrils are getting bigger in and out and breathing really heavily. So those are starting to be signs of more of a lower respiratory tract infection.
Yeah, I would fully agree with Fiona. I mean, the runny nose and the mild cough is suggestive from so many of the viruses that we see during the winter and late fall. And so it's very difficult to distinguish unless you do formal testing. And no one's going to do formal testing on all these babies because they do know that there is such a huge spectrum of viral illnesses that are very, very similar in terms of their presentation. The flu, the parainfluenzas, the rhinoviruses, the list just goes on and on. And so until the babies start showing most signs of distress, that is the time to actually start becoming anxious and to seek medical attention. The earlier you seek the medical attention when those symptoms start manifesting, the better it is. And I think Fiona mentioned one of the important things is also the inability to feed. So I think that is a striking feature that parents tend to overlook. Oh, baby's not feeding that well, but actually is the baby sucking and feeding on the breast or bottling as he had done previously? If that's not happening, then this baby hasn't got the energy to actually sustain respiratory activity. And that is a good sign that you need to seek help and at least come to the hospital for attention or to a clinic for attention or visit the family doctor if you have the opportunity to do so. Yeah.
And that's also why monitoring your infant's output for urine is very important because it's one of the first questions someone's going to ask you when you bring them into your family doctor or to the hospital. They say, are they having enough wet diapers? And that is a sign that they're dehydrated and they're not feeding enough. And are they not feeding enough because they're unwell?
That's a great tip, Fiona, for people to track. If they're thinking it's getting to the point you need to seek medical attention, then to pay attention to that output so you can share that with your medical team. And Sarah was talking about that testing that you mentioned, Bosco. Yeah, so looking at ex-preemies with BPD, how important is it during an ER visit with symptoms presenting as rhino or RSV to actually swab for RSV? Does
Absolutely.
it or could it change the care plan?
That's a great question. And
Yeah.
we know that infants with BPD are considered under the umbrella of relatively high risk. So if a child with BPD is presenting with those symptoms and signs, and especially if the child is less than 2 years of age, but more importantly, less than 6 months of age, where the incidence of RSV is the highest, then it is very important to maintain good surveillance, either in the emergency room and or to swab the child to exclude RSV. And I think most of the ER physicians recognize and appreciate that BPD, congenital heart disease, falls under that umbrella that, you really need to watch very, very carefully, and to make sure you're not dealing with RSV versus all the other viruses that Sarah's put into the chat box. Great question.
So, Bosco, one question for you, because I went to emergency many times with my son the first few years with respiratory illnesses, and sometimes it deteriorates very quickly. And so how parents can advocate for that? Because I had the bad experience in a community hospital. I had to do CPR on my son inside the hospital because the team didn't act fast enough to see that he was deteriorating really quickly, and it wasn't RSV. So how can families be more proactive and really advocate, knowing what we know now, that RSV can really affect the babies or other respiratory viruses that are around in the community at this time of the year?
Yeah, I mean, it's the recognition and the appreciation, right? I think, education is so important. And it's not just education of the families, it's also education across the board for us as healthcare professionals to truly have that understanding and appreciate what the red flags are. And there have been really good studies that have come out of sick kids to appreciate which are those red flags. And certainly children with underlying comorbidities, such as BPD, CHD, the extremely premature babies who have left the NICU, certainly within the first 6 months of age, a chronological age, should be actually observed in the emergency room for longer periods of time to ensure stability before this child is discharged home. And I think as the awareness for RSV is growing, more and more, in fact, physicians in the various institutions, not just the tertiary care units, but also the secondary level care units and the primary level care units, your most basic community hospitals, are getting to understand the implications of watching these kids very, very closely when they come to the ER. Certainly, you can select under the umbrella those ones who are potentially at risk for the child getting worse. Absolutely.
I just add that I think this, I think the situation is getting a lot better in terms of testing, and because of the new monoclonal, long-acting monoclonal, the maternal vaccine. So there's a lot more noise about RSV in general among the healthcare professionals. But also, I go back to my thing about COVID. I think that's changed. That's been a game changer as well, because I think when there was very little viral testing, now we're seeing it. And Bosco and I work with healthcare professionals across the world, and even sort of in resource-poor countries, they're now saying they're testing a lot more routinely. So I think things have changed. There's a lot more access to tests, and people are seeing it does make a difference. So I think things are improving, certainly.
We are going to wrap up. Sorry,
I was just going to
Bosco.
say, and more so in the winter, really.
Yeah. I was going to say we're going to wrap up our time together, but wanted to just ask the question, because you're saying we're in a better place now than we have been in terms of RSV and coming into that season. But what are your hopes for the future? Where should we be heading with this information and with those survey results? What are we hoping to see come out of the position paper, the survey results in terms of RSV?
Barry, you can go first, and then I can talk about prevention. Go on, Barry.
I mean, my position is that all infants should be protected, and I think that's the ultimate goal. And I think particularly when there is now 2 monoclonal antibodies, there's a maternal vaccine now coming out. There should be a childhood vaccine. It's getting to the point there should be no excuse not to have children protected. And I think particularly that disparity, that I know, we've advocated and Fabiana's mentioned across Canada, it shouldn't be sort of depending on where you live means you actually get protection or not. It should be all infants, in my view.
Yeah, I can quickly add to that from the point of view of prevention. I mean, there are now papers starting to emerge looking at the impact of just giving nirsevimab. So, for example, in the US, the American Academy of Pediatrics have projected that just with the use of nirsevimab for all children, preferentially under a year of age, and I said for some who are up to 2 years of age or 18 months, they're projecting that there will be a reduction in those healthcare costs up to approximately $600 million. So, and then if you combine that with what they're projecting with the use of RSV vaccine in pregnancy, coupled with nirsevimab, the reductions are going to be phenomenal. So I think there is great hope for these new strategies that are just around the bend. If they get adopted universally, we may see a gradual decline and maybe even almost disappearance of RSV if the protection becomes good. Yeah.
Okay, Bosco, can we just talk to people a little bit about the maternal vaccine? Because we know moms who deliver very early, the babies don't get the antibodies from the last trimester of the pregnancy. So they lose that immunity from the mom. So the debate, as far as I understood from Dr. Jesse Papenburg last week, is to give to moms later on the pregnancy. So our population of preterm babies, they would lose that regardless. But that's why the prevention afterwards is very important for our babies. So talk a little bit about that before you wrap it up, Leah, just to clarify that piece.
Okay, well, you're absolutely correct. If you look strategically at the conducted study, the parents who enrolled in the RSV vaccine were mums between 24 weeks and beyond. We do know that antibodies are most specifically transferred after 30 weeks gestation to offer due protection to the baby. There was a small signal from the RSV vaccine study that there was a slightly higher incidence of prematurity in the patients that actually received the vaccine. But one needs to recognize predominantly those patients were recruited from South Africa, where the incidence of prematurity, albeit is higher anyhow. So, but just from the precautionary point of view, just to let you know, the US has made a stand and are just targeting patients between 32 to 36 weeks to receive the vaccine during pregnancy, because they know there is an absolute guarantee that the antibodies will be transferred. Maturity is much, much lower if given during that time period. So that is what they're doing. What are they doing across the world? Well, we heard from one of our colleagues that Barry knows extremely well. In Spain, they've adopted giving the RSV vaccine to pregnant women even as young as 24 weeks gestation, because that's what was enrolled in the scientific study. But when you nucleate the data from that scientific study, majority of the patients on the average were 30 weeks gestation. Okay, 30 weeks gestation rather than the lower gestation age categories. So even from the original study, although there were very few patients recruited between 24 and 30 weeks gestation, the average was around the 30 weeks. And that's why the US have gone slightly beyond the 30 weeks. They are targeting 32 to 36 weeks. Hope that's helpful. And yeah, for the younger premature babies who deliver early, you're quite correct. It is going to be nirsevimab. Absolutely. Okay, I think that's important to recognize. Yeah. And of course,
no, it's not available in Canada yet.
it's not been, yeah, you're quite correct. It hasn't been approved by Health Canada as yet, the RSV vaccine for pregnant women, but it's been approved in the US.
Thank you. And for, I think, all of you watching us live today, there is a very interesting webinar given by Dr. Jesse Papenburg. It's on our website. He talks about the maternal vaccine. He also talks about safety and efficacy of nirsevimab and safety and efficacy of palivizumab. So it's all in his presentation from October 24th, pretty much, I think is that date. It's on our website. If anybody's more interested in learning more about this, very scientific presentation by Dr. Papenburg, and it's available now, so people can download and watch actually on our YouTube channel as well. So that's all from me, and I hope everybody stays safe this winter. We hope for a mild RSV season, not to be repeated what we saw last season.
Absolutely.
Thank you, everybody, for joining us and for this great conversation, and for those who joined us online as well. I think when we get people together who are experts in this kind of field, then we have these awesome discussions, and even to hear what's on the horizon for RSV. You've given me hope, Bosco, when you're saying that maybe we won't even see it in the future. So thank you for sharing today.
Wonderful.
Thank you.
Thank you.
Thank you.
And thank you, everyone, for joining us for this special Preemie Chat. This special edition is sponsored by Sanofi, with supporting sponsorship by AstraZeneca in collaboration with FiCare and CAN. And just a reminder that if you missed part of today's episode, or if you want to re-watch it or see any of our past episodes, you can do that by heading over to Canadian Preemies .org, and that is the Canadian Premature Babies Foundation website. And there you'll also find the many resources and support options available to you. We talked about a few additional resources that are on there today in today's programming. There's lots about RSV and about upcoming World Prematurity Day. So as I mentioned at the beginning of our program, that November 17th is World Prematurity Day, and we have a lot planned throughout that whole month, including our live sessions on Fridays that we'll be looking at skin to skin, which is part of the global theme for World Prematurity Day this year. So don't miss our special Preemie Chat on November 17th, but also everything that's happening throughout the month of November. You can find all of that on CPBF's website. You'll also be reminded there that CPBF is a charitable organization, and it depends on support to continue its important work. And you heard some of that important work today when we talked about advocating and putting out position papers. This is how we give families a brighter future. So consider while you're there how you can support CPBF in its mission to empower families of premature babies in every step of their journey. Don't miss next Friday's Preemie Chat. It's again at 1 p.m. Eastern Time right here. We're going to be talking about nurture science and zero separation. It is very interesting. Again, it falls under that skin to skin umbrella. And we're going to be talking, even kind of looking deeper into skin to skin and why that zero separation is so important for NICU families. You won't want to miss it. I hope you all have a great weekend.